Welcome everybody once again to our webinar, and thank Don Mitkus, our presenter for today's webinar on self-harm. Don, thank you for being here with us today, and I appreciate your expertise. I'm sure that our presentation today will be excellent. And if you have any questions for Don, you're in listen-only mode right now, but you can enter those questions either in the chat or in the questions box on your display on the right-hand side of your computer. And we will take those questions, and I will ask those questions of Don if necessary. And at the end, of course, we'll open the lines up so you can ask any sorts of verbal questions that you'd like to ask. So I'm going to turn things over to you, Don, to introduce yourself and to get us started.
All right, thanks, Dale. Okay, so let me. Okay, thanks again. Yeah, again, my name is Don Mitkus. I'm an LCPC and currently am the clinical liaison for the Center for Self-Injury Recovery Services and Center for Eating Disorder at Alexian Brothers Behavioral Health Hospital, where we have a number of programs that treat non-suicidal self-injury. So our goal for today is to do an overview of this particular behavior and phenomenon, to give you a little bit of an understanding of this population, and talk a little bit about the motivations and what drives the behaviors, and talk a little bit about what to a little bit about what you can do. The interventions for self-injury are usually better handled in outside the school setting. These kids can be a little bit toxic in groups, so putting them together in groups or support groups can be a little bit messy, but we'll touch on that in a little bit. So again, so we're here to talk about understanding self-injury. What is self-injury? Well, there is a group of researchers that got together about 8 years ago that studied the topic of self-injury and formed a network called the International Society for the Study of Self-Injury. We just hosted their conference, their international conference last summer here in Chicago. And it's a small group, but they came up with a definition of non-suicidal self-injury, which is the deliberate self-inflicted destruction of body tissue without suicidal intent and for purposes not socially sanctioned. So that's kind of a weighty definition, but really what it comes down to is that the goal of the behavior is not necessarily to die or to end one's life, but there are other reasons that people are engaging in these behaviors. And also, if these behaviors are socially sanctioned, it's not necessarily considered non-suicidal self-injury. So where these lines might be blurred in today's adolescent and young adult culture are things like tattoos, body piercings, things of that nature. What it really comes down to is what's the motivation behind the behavior? Is it self-expression? Is it art? Or is there another reason that they're engaging in these behaviors? And that's what we'll define it as expression of individuality versus non-suicidal self-injury. So there's been, this behavior's gone by a number of names and undergone a bit of an evolution over the past 25, 30 years that we've been really kind of studying it. Parasuicide, self-harm behavior, self-directed violence, self-mutilation, deliberate self-harm. There are different organizations, different researchers that use different terms. We like to use the term non-suicidal self-injury as being the most specific descriptor of what the behavior is. So it may be referred to, or you may read in literature these different descriptors of it, but for the purposes of our discussion here, we'll refer to it as non-suicidal self-injury. So here's the why do people self-injure? That's usually the first question that someone who first encounters this behavior or doesn't have a lot of experience with this behavior asks. Why in the world would someone hurt themselves? What on purpose? It doesn't make any rational sense. And there's two overarching reasons. One is interpersonal, one is interpersonal or social. And the specific reasons, and the reason we have these little things afterwards is it's going to, we'll talk about the prevalence of each reason, but it could be for autonomy, it could be to keep themselves from dissociating, to keep them grounded, it could be for affective regulation or calming themselves down from an agitated state. Paradoxically, it can be the reason might be for anti-suicide. So rather than acting on an impulse to kill themselves, they will self-injure in order to keep themselves from acting on a suicidal impulse. Interpersonal boundaries, interpersonal influence. So we're talking about influencing others, usually someone in their family system, by to get a particular reaction out of someone in their family or a significant other or friends or social cohort. If you've worked with these sorts of kids at any level, oftentimes there will be a parent or a significant other that'll say, well, they're just doing it for attention. Well, you know what? Yes, that could very well be that they're doing it for attention. And the reason they do it for attention is because it works and it gets them attention. But that they are doing it just for attention, cry is often dismissive of the behavior and the seriousness of it. But it's could very well be that they're engaging in this behavior to get a need met that's going unmet at that time by someone in their family. Marking distress. They want people to notice that they are in pain internally. So the self-injury, these physical marks will show the world the type of pain they're experiencing on the inside. Peer bonding. Now this is something that we've probably been more, because self-injuring behavior is not a new phenomenon. This is, people have been engaging in self-injury, non-suicidal self-injury for centuries. But the more recent phenomenon that we've seen that's somewhat remarkable is the age of entering into this behavior. And we're seeing it quite a bit with middle schoolers, with or even elementary school kids. And during that stage of personality development, they're undergoing identity formation, particularly in middle, 7th, 8th grade, where they're figuring out who they are by joining with other people that are doing similar things or have similar social interests. And so what we're seeing is kids that are socially getting together around their self-injuring behavior. Not necessarily self-injuring together, but that's their common bond, is that they self-injure and they identify themselves as in a way they identify themselves with that behavior, much like a football player might identify themselves as a jock, or someone might self-identify as a geek or a nerd. They identify themselves as cutters. What I would urge you to do, it doesn't matter what and this is my momentary soapbox, is if you do work with kids that are engaging in this behavior, or discussing kids that are engaging in this behavior with other professionals, I would urge you not to identify them by their behavior. So we often hear parents or other well-meaning people referring to them as cutters. They're a cutter. This kid's a cutter, and especially with our younger teens or preteens, it's quite damaging because they're identifying themselves as part of their normal adolescent or pre-adolescent development, and if they come to identify themselves as a cutter, and that becomes their a persona, so to speak, or it becomes integrated in their identity, it becomes much harder to treat later on because it becomes integrated. So we encourage people not to identify people by their behaviors because it winds up doing harm, and it feeds into the process. So it's a kid, it's got a problem, kid's engaging in cutting, engaging in self-injuring behaviors. That's fine. I would ask folks to refrain from calling them cutters. So there's my soapbox. It's over. Moving on. Revenge. Revenge is a motivation or a reason to self-injure. You slighted me, so I will get you back by hurting myself. Often this is revenge against or perceived revenge against a family member or a loved one. Self-care, which is somewhat related to the anti-suicide. Self-punishment, feelings of guilt, shame. Often victims of trauma will engage in self-injury for this reason, where they feel worthless, they feel that they're not worthwhile, so they will punish themselves by self-injuring if they do something they feel that they need to atone for. Sensation seeking, this is more for adrenaline junkies, so those that are seeking to feel something. And toughness, so this is someone who we see this more with boys than with girls, but as a way to demonstrate that they are resilient and tough to those around them. So these are the reasons, specific reasons that we've identified as, and there are possibly others, but these are the main 13 reasons that we identified and have been looking into and researching. So when we do an inventory with these individuals, we ask them to complete this sentence. When I harm myself, I am. And these are some of the responses that we get for the different reasons for self-injury. So affect regulation, I'm calming myself down. Self-punishment, expressing anger towards myself for being worthless and stupid. Anti-suicide, putting a stop to suicidal thoughts. Causing pain so I'll stop feeling numb for those that are dissociating. So self-care, creating physical injury that is easier to care for than an emotional distress. So you can see these are some fairly, when talking with these kids, they're doing this, engaging in this behavior for a reason. They're getting something out of it. They're not doing it just to do it or just to get attention. There's a motivation behind the behavior. And getting to helping them, you really do need to get to what is motivating, what is driving this behavior. So this is something that this is a helpful question to ask is, so when you self-injure, when you hurt yourself, when you harm yourself, what are you doing? So, answer, finish the following sentence. When I harm myself, I am. And their answers, their responses can be very enlightening as far as what the motivation for behavior is, which can also cause, point you in the direction of other issues to explore. If you're assessing a kid for, perhaps for risk to harm of self, if you're assessing how serious the behavior is, assessing what an appropriate intervention might be or an appropriate referral might be. If someone is is harming themselves to put a stop to suicidal thoughts, that's a kid that really needs to get to a safe place. Just because the self-injury behavior is non-suicidal doesn't mean that they can't convert into suicidality very, very quickly, and they can. those that engage in non-suicidal self-injury are at a higher risk for a suicide attempt or to flip into suicidal ideation. So when you're talking about assessing whether or not this kid needs to go for an immediate assessment at a facility, you need to assess their suicidality and how frequently do your regular suicide risk assessment, but also take a close look at what's motivating their self-injuring behaviors. So this is some data that we've collected at the hospital. We've seen over the past 10 years, well over 2,000 people that suffer from self-injury. So we've been able to collect quite a bit of data on this particular behavior and phenomenon, and kind of drill down to what's the primary reason people engage in these behaviors. As you can see, a pretty serious percentage of people engage in self-injuring behavior for affective regulation. So they're going. Let's see if we can go back for a second here. So again, AR, affective regulation, and self-punishment being a second, but not too distant second. So about 40% of people who engage in self-injury engage in it for self-punishment. 65 to 75% of people engage in it for affective regulation. So they're doing it to cope, to deal, to cope with strong emotional states that are very uncomfortable for them. So it provides a calming effect for them. In fact, the act of self-injury, when it gets to some form of regularity, will actually cause a release of endorphins. So there's, you may be familiar with that from concept of a runner's high. Runners get to a certain point and they feel they hit a wall, and then they get right through it and they feel an elation and feel great, and they get that runner's high. That's a release of endorphins from physical exertion. Well, those that self-injure can self-injure and get that feeling fairly a lot quicker than having to run 6 or 7 miles. So again, affective regulation by far is the most common reason, primary function of an individual self-injury. They're trying to cope, they're trying to deal, and they discovered a way that is not healthy or pro-social. Is self-injury all cutting? It's not. There are a number of ways that people will self-injure. Again, for all those reasons that we said, but it may manifest itself in different ways. So cutting, of course, is by far the most common form of self-injury. But no matter how controlled your environment is, families will take away cutting implements, razors, razor blades, protractors, et cetera, tools that their kids might be using to self-injure. But in reality, all they need is a fingernail or their teeth, and they can self-injure. So scraping and scratching is the second most common form. Banging head or limb, that includes things like punching walls, is another form of self-injury. We see this more frequently with our males who self-injure, who aren't necessarily cutting, but they're those extraordinarily angry outbursts where they're punching things or hitting walls and busting up their hands and knuckles to deal with that anger, that very uncomfortable rage, is a form of self-injury. Self-choking, burning. Healing prevention means that picking at old wounds is another way of self-injuring, or drawing blood using needles or pins is another form of self-injury. There was a bit of a ruckus a couple of years ago regarding embedding. The media got a hold of it and made a pretty big deal out of it, where the concept is someone would embed a foreign object like a pin or a piece of pencil lead or something like that under the skin they make an incision, insert it in there, and that way they could rub where that foreign object is embedded and get a similar reaction or sensation as if they had self-injured. So we see that very, very infrequently. It's not as frequent as the media portrayed it out to be back a few years ago, but it is a form of self-injury. But these, by far, these 7 types of self-injury are the most frequently used. Typically, how severe is the injury? Most are, and how do you determine what's mild, what's moderate, what's severe? Mild is something that's an abrasion. It could be something as simple as taking a fingernail and scratching it back and forth until the skin becomes raw and irritated. Or very superficial lacerations with a blade of some sort are considered mild. The single mild lacerations can be considered mild self-injury. Moderate is where blood is drawn, and severe is where medical attention is required to attend to the injury so it doesn't get infected or complicate into some other issue or problem. So that's someone who's doing multiple large areas of self-injury. So 10, 15, 20, 30 lacerations on arms, legs, stomach. They're often for those that are doing it for affect regulation, they tend to hide their self-injury. They tend to cover it up, and oftentimes when it's uncovered that they're injuring themselves on their places that are potentially visible, like their arms, they will often move to less visible areas like the chest or the abdomen, upper legs or thighs, genital areas. If they're discovered and they're not being treated for the behavior, if the motivating factors that are driving the behavior are not addressed therapeutically, they will continue to self-injure because they are getting something out of it. They will find other ways, other places to self-injure, which is why it is very it's vital for these folks to be seen and assessed fairly as soon as they're identified. So this way the extent and the severity of the self-injury motivating factors can be determined, and appropriate counseling or therapy or treatment can begin. If it's it's just we're gonna watch you, we're gonna take stuff away from you, we're gonna ground you, family tries to contain it, they will find a way. These kids are quite clever and highly motivated to engage in behaviors that help them deal with their internal pain. That they will find a way, and that's when it can get much more serious because it becomes hidden, and it can be more severe, and they're injuring in more sensitive, more vulnerable areas of the body. Another question we get isn't this just borderline personality disorder? Aren't they just borderline? And borderline personality disorder is something that's been thrown around so frequently that it's somewhat lost its so we'll describe quickly herself is their view of where it might be that other people have the answers to fixing them, but they also are the ones who cause all of their problems. They believe they're unlovable. There's no one who's going to be strong for me or care for me, but I can't cope on my own, and I need someone to rely on. So there's paradoxical thing going on with those with borderline. So they feel like they're going to be abandoned at any minute by those that are supposed to be supporting or loving them. So oftentimes they abandon them first. So they are often demanding, I love you, I hate you. get away from me. They can be quite, they're extraordinarily taxing on relationships, and this disorder is extremely destructive to relationships. Typically, they present as very angry or depressed, mood swings all over the place. So this is something that, and are all self-injurers, those that self-injure, do they all suffer from borderline personality disorder? Well, there's, this is a mnemonic for diagnosing borderline personality disorder. So if they meet 5 of these 9 criteria, they're likely to have borderline traits at the very least. So fears of abandonment, mood instability, suicidal or self-injurious behavior. And this is the only place in the DSM-4, and we'll talk about this in a second, but this is the only place in the DSM-4 that mentions self-injurious behavior. It isn't mentioned in any other place. The relationships tend to be very unstable or very intense. They tend to be very impulsive. They have a very poor control of their anger. Identity disturbance, associative, paranoid, feelings of emptiness. So if someone meets 5 of these 9, at the very least, they could be said to have borderline traits, if not a full-blown personality disorder. But you got to work with someone for about 6 months before you can actually diagnose them with a personality disorder. It was in DSM-4. It's changed with DSM-5, but not everyone is using that yet. So in adolescence, and you have to be over 18, but there is some strong support that borderline traits or borderline personality disorder can exist in adolescence. There is some genetic basis to this personality disorder. The thing about medications and therapy and treatment, dialectical behavioral therapy is pretty effective in helping those with borderline personality disorders stay and maintain relationships. And sometimes that's long enough to have children, and those children are more vulnerable. And then there's common risk factors over time. So if there's someone experienced trauma in a family of origin, has children, they are still part of that family and could very well be at risk for those same traumas. So traumas tend to be a pretty strong indicator of a predictor of borderline personality disorder. So do all self-injurers have borderline personality disorder? And the answer is no. So what you can see here is that it peaks at about 35%. So about 35% of those that we've administered the borderline evaluation of severity over time, about 35% of them would meet criteria for borderline personality disorder. So the answer to the question is, are they all borderline? No, they're not. Most of these folks have found a behavior that is effective for them in coping with difficult feelings, emotions, and emotional states. So it doesn't necessarily mean that they have personality disorder. Is non-suicidal self-injury a reenactment of abuse? Answer that, simple answer is no. So there's Klonsky, who is actually one of the more prolific researchers in the area of non-suicidal self-injury, did a meta-analysis of, well over 40 studies. And the correlation between non-suicidal self-injury and childhood sexual abuse was about 0.23, which is not a very strong correlation at all. And for those people that have come through our programs at Alexian Brothers, about a third have indicated prior physical or sexual abuse. So as you can see, it's fairly comparable to the percentage of people that suffer from borderline personality disorder that engage in self-injury. Although I haven't seen a study that puts those two together yet, so we'll see. So how common is it? Amongst adolescents versus adults, it's far more common with adolescents, as you've probably seen. Up to a third of adolescents have engaged in at least one episode of non-suicidal self-injury, which is not surprising when you consider that adolescence is a time where kids are trying out different behaviors and different methods of dealing and coping with strong emotional states. They're experimenting with alcohol or other drugs. They're experimenting with other risk-taking behaviors. As non-suicidal self-injury has become more common in the adolescent culture, kids are going to try it out. Now, the amount of kids that repeat and fall into that repeated pattern of non-suicidal self-injury, that percentage is a little less than 7%. Now, if you think about that, that's still a remarkable number, because if you have a school of 1,000 kids, 70 of them are engaging in some form of non-suicidal self-injury, which is quite a few. Adults, certainly the frequency of non-suicidal self-injury is less, but a greater percentage of them go on to repeat the behavior. So about half those adults that start the behavior will engage in a repeated pattern of it. The age of onset, according to the research of Klonsky and Zetterquist, is 12 to 15. At Alexian Brothers, where we have a partial day hospital and IOP and an inpatient program for non-suicidal self-injury. So for those that need a higher level of care at some point, the average age of onset for our patients is 8. So to give you perspective, 3rd grade is when, on average, people that wind up needing a higher level of care start engaging the behavior, which is indicative that the younger someone starts engaging in this behavior, the more likely they are to have some serious problems with it later on. So what are the risks for self-injury? What makes someone more vulnerable to engaging in this particular behavior? So exposure to frequent, intense, negative emotional experiences. So this could be multiple losses. This could be living in a chaotic environment at home, parents in conflict, parents divorced, et cetera, et cetera. Those that have poor distress tolerance or coping skills. So these are kids that have little resilience. These are kids that have been rescued and not had to develop those self-reliance skills to deal with adversity. So those that have been rescued a lot by their families are at higher risk to develop this particular behavior, because they're searching for something that's going to help them contain their distress. Those that are very emotionally reactive or emotionally labile. Those that tend to be isolated or ruminative. Those that ruminate on negative feelings or emotions. The worriers. Those that, oh gosh, I did something wrong. I'm terrible. That's awful. I'm a horrible person. Dissociation, which often happens for victims of trauma. Those that become disconnected from the reality around them, and kind of tune out, so to speak. Maltreatment, again, abuse, any form of abuse. Parenting conflict, as we talked about. Derogatory sense of self. Socially isolative, poor social skills. Here's the thing about the social contagion of self-injury, is that this is a social cohort that doesn't require that you have any particular athletic ability or particular IQ or skill set to be a part of. You don't have to be a football star to be part of a social cohort of those that self-injure. So it's for those that have poor social skills, those that are socially isolated, that don't have a group to identify with. This is a potential, and are feeling depressed and lonely to begin with. This is an easy way to easy entry into a social group is by engaging the behavior. Identity confusion for those that are struggling with their sexuality. It puts them at risk because, again, they're experiencing a very distressed emotional state, and often they're distressed because they can't share it with others, perhaps, and that conflict causes a vulnerability to self-injury. Why self-injury? It's effective. It reflects their internal experience. If they're again, as I mentioned before, if they're feeling like they are worthless and horrible and terrible on the inside, this is a way that they can show the outside world how they're feeling without actually having to communicate it verbally or in an appropriate way or a socially acceptable way. Again, it's effective. It does the job. It causes many other issues. It causes prevention, development of other healthy coping skills. But at that time, for that moment, it does the job. So it's learned and it's reinforced. So every time they do it and they get pain relief or distress relief from the behavior, it reinforces that behavior is effective. So this is something that's self-perpetuating. So if the first time experience isn't aversive enough to them, that's when the repeated pattern can start. It's much like those that start engaging in alcohol or drug use. If their first experience is horrible and terrible and didn't provide them the relief that it was supposed to, they're unlikely to do it again. But if they get, if they have a subjectively positive experience, their chance of repeating behavior is likely. So, as you may well know, about a little over a year ago, we got the DSM-5, which replaced the DSM-4-TR. Non-suicidal self-injury was in the running for being included in the DSM-5. However, it is not. And there's a reason for that. The diagnostic reliability that was being proposed for non-suicidal self-injury had very poor reliability. Basically, the review group that was reviewing non-suicidal self-injury at the APA for inclusion in the DSM-5 said there's just not enough good research yet. So we'll take into consideration for a future iteration of the DSM-5. As you may or may not know, DSM-5 it's unlikely there will be a DSM-6 for quite a long time. What they will do is do updates like a DSM 5.1, 5.2. So we're going back to the drawing board and doing more specific research so we can get this included as a diagnosis. So those that suffer from self-injury are typically diagnosed under a depressive disorder or mood disorder or an impulse control disorder. So for those that have reached the point in their behaviors where they're, just to give you an idea of the demographics, those that are admitted to the hospital for this behavior. So this is those over 500 patients we collected data from. They were admitted inpatient for this behavior. Their average age was 17. A significant majority of them, 72%, were adolescents. Almost 16% were emerging adults, which are the 18 to 25-year-old age group. By far predominantly Caucasian, 1 out of 10 being Hispanic, and this is not a very common behavior at all in the African American community. This is a copy. This is something that if you have interest in, it's our assessment of self-injury. It's available online on our website under there's a area for forms. You can download this and use it if you so choose. But it gives you a place to start to assess someone if they're engaging in self-injuring behavior. So, for instance, here's one of the questions in the last year. How often did you intentionally, on purpose, do the following things to hurt yourself or cause pain? So carving into your skin, things, designs. So how many days in the past year and how many times each day? And at what age did you start? So it gives you an idea of frequency. It gives you an idea of longevity. It gives you an idea of when they started engaging in the behavior. So again, the earlier that someone starts the behavior, the ones that are doing it more frequently are the ones that will likely need some form of higher level intervention. So and then it goes over past year. So if you think about hurting yourself in the past year, that can lead into discussion of how recent was that last thought of hurting yourself, how frequently are those impulses, and what they expect out of the behavior. So which leads to the what's the motivator, what's what factor is driving the self-injuring behavior. And then there's what other things, what other flavors go with self-injury? What things do we often see that co-occur? It used to be that I firmly believe that the single diagnosis patient is these are folks that we see at the hospital. The single diagnosis patient is more the exception than the norm. We see a lot of people that are presenting with multiple issues simultaneously. So as you can see, there's a very high comorbidity with the depressive disorder, high comorbidity with anxiety disorder, impulse control disorder, drug use, eating disorders, bipolar. Not so much with some with PTSD, some with schizophrenia, but by far depressive disorders and anxiety disorders are the most frequently comorbid conditions that go along with self-injury. So if you're seeing a kid that's self-injuring, these are areas you need to explore as far as doing a proper assessment and figuring out what else is going on, because there's a good chance there is other things going on there. So when does someone need treatment? At one point do you say, okay, this is beyond what we can kind of deal with and support here in the school? Those that are repeatedly self-injury, those that have done it more than 5 times in the past year, that has developed a pattern, those folks need intervention. Those folks need treatment in order to address the behaviors. Even if it's less frequent, any type, even if it's a single episode, serious self-injury, meaning it requires medical care, which means that they need to go and get stitches, sutures, staples. They need to, those that may be ingested a foreign object, those are the folks that need to be seen immediately. Again, suicidal logic behaviors, risk to self, or certainly needs to be seen immediately. If there's a comorbid disorder, if it becomes pretty clear that this kid also has an eating disorder or a chemical use issue, then it's a fairly complex presentation and needs treatment rather than just support. If they're injuring while they're under the influence, meaning that they're normally if they're sober and their impulse control is a little bit more stable there and they're not inclined to self-injure, but when their inhibitions are impaired because of mood-altering chemical and they self-injure at that time, then again, that's a complex presentation that really needs some treatment to impact. And then repeated strong urges to self-injure. So those that are ruminating about it fairly frequently typically need some form of treatment to alleviate that rumination. So at this point, we have about 5-10 minutes. Be happy to entertain any questions you might have.
And I am opening up the sound, so if you have any questions for Don, please feel free to go ahead with those questions. Don, I actually had a question as I was looking through your slide on the racial kind of breakdown. Any indication as to why it was primarily white non-Hispanic versus the African American and Hispanic communities?
You know, that's a good question. I have not seen any research on that, but we did find that interesting as well. I believe that there's a researcher, Diana Mellencamp, out in Eau Claire, Wisconsin, that I believe is looking into that, but there's not data on it yet.
Yeah, kind of gut reaction was, I wonder if it's not something cultural in terms of the prohibitiveness of something like that in Hispanic and African American communities, just kind of eyeballing it.
And it could also be that it's not as the behaviors might not be identified as self-injury, but you know, certainly those kids that are getting into frequent fights, those kids that are injuring themselves by angry or aggressive outbursts, you know, certainly can be potentially viewed as self-injuring. So it could be that the behavior is just not being overly identified in those cultures as they are in Caucasian culture.
Miriam, do you have a question?
Yes, I do. Can you hear me?
Yes, I can.
Okay, in the beginning you had mentioned that the individuals that are engaged in this behavior can be often toxic in groups.
Yes.
And I'm from a school. Would you recommend that when you bring people into a group setting, that would be one of the questions? It's pretty important to ask.
It can be, because the social contagion of self-injury it's so powerful, and it's the conversations that occur amongst group members when they're not in group, that, okay, well, this is someone else who's obviously suffering like I am. And that's where the contagion tends to come into play, is outside of group time, where none of us are around, so that's why it's important to identify those that are self-injuring, so they can be seen more on an individual basis, perhaps either with the SAP or the social worker, or someone who can kind of meet with them one-on-one, so they're not introducing others to that behavior.
Okay, thank you.
Sure. Just so you know, there's about 3.5 years ago, we did at Alexian Brothers, we did a full-day presentation workshop on self-injury, and myself and one of my colleagues were saying, this is some really good stuff, we should write a book. And we got the team together and we said, well, yeah, this is a great idea, we should write a book about how to address self-injury that the people on the front lines can use. Yeah, we can knock this out in 6 months. Well, we learned that getting 10 people together to write a book takes about 3 years, not 6 months. So there is a book that we put together, Self-Injury: Simple Answers to Complex Questions. It's designed to help those folks that are in schools, in hospital emergency rooms, parents, families, loved ones, to get some answers about how to address those folks that are struggling with this behavior. If you click on the website, there's more information on it, but we try to make it as user-friendly as possible, and if you have a question about this particular issue, to make the answer easy to find. So were there any other questions, concerns? My contact information is here on this slide. If you do wind up having a question after we're done here, please don't hesitate to give me a call or shoot me an email. I'd be happy to talk to you about it.
All right, hearing no other questions here, Don, I think I'm going to take back control here, and I will send out the slides to everybody who attended at probably later this week. I just wanted to, again, remind you of our upcoming webinars. And so if you would like to participate in those, you can go to our website and register for those. Thank you all for coming, and I hope you enjoyed today's webinar. Don, thank you so much for your presentation and your expertise, and we look forward to hearing from you in the future. Thank you, everybody, for attending.
Thanks, Dale.